Delirium usually presents in the person in a state of mental confusion that develops quickly and usually fluctuates in intensity, representing a change from the individual's normal attention and awareness. There is a reduced awareness and responsiveness to the environment, which we see with decreased attention to commands. The person is often disoriented and incoherent and has severe memory disturbances. Hallucinations and delusions are not uncommon and can cause harm to the patient if not monitored. Delirium is a syndrome that is always secondary to another condition, such as general medical conditions or substance abuse, medications, exposure to toxins, or it may have multiple etiologies. Delirium is a transient disorder, and if the underlying physiological disturbances are corrected, complete recovery should occur. However, nurses and other healthcare workers need to be very cognizant of the fact that if the underlying etiologies are not addressed, dementia and even death may follow. It is also important to note that delirium may easily occur in a patient with dementia. Delirium is one of the most commonly encountered medical disorders in medical practice. It's often overlooked or misdiagnosed. Older hospitalized patients are at significant risk for delirium as well. Delirium can be present in 15 to 53% of older individuals postoperatively, and 70 to 80% of those who are in intensive care units. Furthermore, 60% of nursing home residents and as many as 75 to 85% of people with a terminal illness develop delirium near death. Delirium occurs more frequently in older patients. Surgery, drugs, urinary tract infections, pneumonia, cerebrovascular disease, and congestive heart failure are some of the most common causes. Delirium is also commonly seen in children with fevers and in terminally ill patients. A delayed or missed diagnosis can have serious implications because of the longer a condition remains untreated, the greater the risk that the condition can cause permanent damage. Depression often masquerades as dementia and can even co-occur with it. Therefore, a clear definition of the three can be useful during the assessment. Table 18.1 offers some guidelines for distinguishing among delirium, depression, and dementia. The essential feature of delirium is a disturbance in consciousness coupled with cognitive difficulties, such as the ones listed. Basically, it consists of cognitive disturbances such as thinking, memory, disorientation, impairment, and perception, as well as attention disturbances. The clinical manifestations of delirium develop over a short period of time, such as hours to days, and tend to fluctuate during the course of the day. Sundown syndrome is a disease in which the symptoms and problem behaviors become more pronounced in the evenings. This may occur in both delirium and dementia. I already mentioned how frequently delirium occurs in certain populations of hospitalized patients, but the financial impact is just as detrimental. It has cost billions of dollars in extra inpatient hospital days and psychological turmoil for the families of patients in which death ensued. Delirium is not, however, a chronic illness. It usually occurs the second to third day in the hospital and caused by other exacerbating factors, as I previously stated. It is vital for the nurse to assess appropriately and notify the physician immediately so that interventions can occur that will correct or reverse the delirium before it's too late. Nurses in the ICU complete a confusion assessment method, or CAM assessment, on every patient, every shift, and if the patient has a change in cognition. This is absolutely a necessity.
I'm going to give you a demo today about how to do the confusion assessment method in the ICU, the CAM ICU, for an intubated patient. So we have our patient here. The first step in identifying delirium would be, does our patient have a fluctuating course? And I have heard from report that my patient has had some agitation over the past 24 hours, so I'm going to assess her. Mrs. Smith. Hi there. I'm going to ask you to do a few things for me in order for me to see how your thinking is. Can you squeeze my hand? Good. I'm going to ask you to squeeze my hand every time I say the letter A. So when I say A, what will you do? Good. S A B E A H A R T. So she squeezed my hand on every A except for one, so I could say that she passed and she does not have delirium. Now we'll start over with a different patient. Mrs. Jones. Hi there. I'm going to ask you to do a few things for me to see how your thinking is. Can you squeeze my hand? Good. I'm going to ask you to squeeze my hand every time I say the letter A. So when I say A, what will you do? Good. S A B E A H A R T. She squeezed my hand too many times at different letters, so I'm going to keep going. Mrs. Jones, I'm going to ask you some questions. Can you say yes or no? Nod your head yes or no. Does a stone float on water? Are there fish in the sea? Can you use a hammer to hit a nail? Is 1 pound bigger than 2 pounds? Because she couldn't answer my questions, she nodded off. I can say that she has delirium at this time. We can also use the CAM-ICU scale to assess if our patient has been positive for delirium. Since they can fluctuate, we're going to do it to make sure that they're coming out of it as well. So we can go through all the steps if we want. Mrs. Smith, I'm going to ask you to follow a few things for me to see how your thinking is. Can you squeeze my hand? Good. I'm going to ask you to squeeze my hand every time I say the letter A. So when I say A, what are you going to do for me? Good. S A B E A H A R T. Good. Even though she passed that, I'm going to keep going. Will you nod yes or no to my question? Does a stone float on water? Are there fish in the sea? Is 1 pound greater than 2 pounds? Can you use a hammer to hit a nail? Can you hold up the number of fingers that I'm holding up with your right hand? Good. Can you do that with your left hand? Good. So she's passed everything. I can say she is negative for delirium now.
Who are you?
Ain't got bees, but he suffered by the penal code, a snail draw, black dope.
It's Saturday.
No, it's not. It's Monday.
No, you're trying to poison me, and I'm going to call the police because that's what you people do here.
Hilda, I just want to give you a little something for pain before we get you up.
I'm going to call the police. I'm
Hilda,
calling the police.
Hilda.
No.
I don't know.
I'm not crazy.
Boy, those people at 7-Eleven, they're always on the phone talking about me.
Well, I called up Ghostbusters.
I'm doing so hot. I think and feel as though people have called me here to electrocute me, judge me, put me in jail.
Can I go back in now? Yeah, I'm getting very uncomfortable out here. I think somebody might be trying to shoot me.
All of a sudden, the room started to change. It would get smaller. If you've been in a castle, and you know that beautiful brown wood all started to close up. You would get one room closing into another, and the people would all walk out and they'd go somewhere else, until it got to the part where here am I over by the door, and it was gradually closing.
Delirium has been described as, quote, a disturbance of consciousness with impaired attention and disorganized thinking or perceptual disturbance that develops acutely, has a fluctuating course, and with evidence that there's an underlying physiologic or medical condition causing the disorder. The condition has been recognized for centuries. In the 1600s, it was described by Servant as mad in patches of lucid intervals. The condition occurs 4 to 5 times more often in persons with dementia, and it's present in 14 to 56% of older hospitalized medical patients. Its impact on one's quality of life and well-being is significant. Delirium increases illness and death, increases nursing home placement readmission, prolongs hospitalization, and causes increased stress on patients, spouses, and caregivers. Within the healthcare system, the disease is far-reaching. Annual care costs for a patient with delirium are about 2.5 times higher. That translates up to about $64,000 per patient for a national financial burden of $40 to $150 billion a year. Most of those costs are coming from post-hospital expenses, including institutionalization, rehabilitation, and home care. Delirium is caused by a combination of predisposing vulnerability factors and precipitating factors. Those predisposing factors include a previous diagnosis of dementia, advanced age, the male gender, a MMSE score of less than 24, a prior history of delirium, depression, alcohol abuse, untreated hearing or vision loss, needing assistance in 2 basic activities of daily living, current use of an anticholinergic, dehydration, sodium abnormalities, history of hypertension, CHF, diabetes mellitus, CVA, or AFib, or admitted for, in current circumstances, urgent surgical repair of hip fracture or elective aortic aneurysm repair. Precipitating factors include infection, injury, pain, hypoxia, hypoperfusion, electrolyte imbalance, recent surgery, use of physical restraints, malnutrition, sleep deprivation, immobility, dehydration, sensory impairment, using more than 3 new meds during hospital stay, bladder catheterization, urinary retention, fecal impaction, alcohol abuse, exposure to an iatrogenic event, acute medical emergencies including heart failure, myocardial infarction, shock, head trauma, seizure, stroke, or other subdural hematoma. Focusing in on for a second time those medications that can precipitate delirium: anticholinergics, TCAs, antipsychotics, anti-inflammatory agents, benzodiazepines, alcohol, digitalis, antihypertensives, diuretics, lithium, opioids, and GU drugs including ranitidine and cimetidine can all prompt onset of acute delirium. Delirium is usually acute in onset, of fluctuating nature and evolving course. Symptoms include attention disturbance, memory disturbance, orientation disturbance, perceptual disturbance, thought disturbance, sleep disturbance, consciousness disturbance, speech disturbance, and psychomotor activity disturbance.
Hi, Gord. It's Donna.
I'm your nurse today. Do you remember me?
I've been looking after you all morning. How are you feeling? Not so good?
Modern-day standards for diagnosis are established by the DSM-4. Those criteria include disturbed consciousness, cognitive change, perceptual disturbance, rapid onset, and evidence of causal physical condition. The confusion assessment method, also known as CAM, is another standardized instrument developed for clinicians to identify delirium quickly and accurately. It can be used in clinical and research settings. The test helps to distinguish dementia from delirium. A diagnosis of delirium requires the presence of acute onset with fluctuating course, inattention, and either disorganized thinking or altered levels of consciousness. Other supporting features of delirium include disorientation, memory impairment, perceptual disturbances, delusions, psychomotor agitation, sleep cycle disturbances, and inappropriate behavior. When appropriate, a complete workup for delirium should go beyond standardized testing or criteria. Diagnosis should include a physical exam, a neurological exam, vitals, a review of medications, a review of alcohol abuse, assessment for Foley's, drains, IVs, monitors, restraints, and any other tethers, and certain labs including a UAUC, creatinine, sodium, calcium, and glucose. If the patient has had a history of recent head trauma, neurological changes, or encephalitis might be of suspect, then adding additional imaging is indicated. The key to treatment of delirium is identifying and removing or treating the underlying cause. In most cases, it is reversible. General measures to consider include maintaining safety, which can be accomplished by a professional sitter or just a familiar face at the bedside, environmental modifications such as continual orientation to new surroundings and providing things such as clocks and calendars, and helping keep patient areas well lit, quiet, and keeping the call light well and within reach. If appropriate, it may be necessary to discontinue any tethers on the patient as well, such as restraints or Foley's. Physical restraint should truly be used as a last resort. Be sure to identify and manage pain and constipation. Provide stimulating activity during the day, work to correct sensory deficits, promote sleep, and strive to prevent dehydration. From a pharmacological perspective, the starting point in delirium treatment should be discontinuing or decreasing any existing doses of hypnotics, psychotropics, or anticholinergics, or as well any other offending medications. At the point of agitation or aggression developing in the course of the illness, the use of trazodone or high-potency antipsychotics such as haloperidol should be considered. Patient status should then be reevaluated every 30 minutes. If the delirium is related to alcohol or benzodiazepine withdrawal, then the patient should be treated with Ativan and thiamine. Prevention of acute delirium is better than waiting for onset and valuable resources to be used. Strategies for prevention include early identification and removal or treatment of underlying causes. Many of the non-pharmacological treatments for delirium become the prevention strategies when utilized prior to onset. Families, of course, can provide a lot of that support. Bringing patients' personal items to the bedside, making sure that they have their hearing aids and glasses, and encouraging low stimulation visits are just a few of the things that families can do to prevent delirium. Families should also inform healthcare providers of any acute changes in mentation or abnormal behavior. They should keep themselves educated on the latest in delirium and delirium-related research as well. For more information, visit the Canadian Coalition of Senior Mental Health or the American Geriatric Society. Arming yourself with the knowledge surrounding delirium may help to prevent its presentation or enable you to cope with it if it does surface.
Generally, the nurse suspects the presence of delirium when a patient abruptly develops a disturbance in consciousness that is manifested in reduced clarity of awareness of the environment. The person may have difficulty with orientation, first to time, then to place, and last to person. For example, a man with delirium may think that the year is 1972, that the hospital is his home, and that the nurse is his wife. Orientation to person is usually intact to the extent that the person is aware of self-identity. Level of awareness is disturbed and the ability to focus, sustain, or shift attention is impaired. Questions need to be repeated because the individual's attention wanders, and the person might easily need to be refocused. Conversation is made more difficult because the person may be distracted by irrelevant stimuli, or they may refuse to talk to you because they don't recognize you. Fluctuating levels of consciousness are unpredictable. Disorientation and confusion are usually markedly worse at night and during the early morning. In fact, some patients may be confused or delirious only at night and remain lucid during the day. It is important for nurses to help patients remain on a sleep-wake pattern. Some clinicians use the mini-mental state exam to screen or follow the progress of an individual with delirium. Nursing assessment includes cognitive and perceptual disturbances, physical needs, and moods and physical behaviors. Illusions are errors in perception of sensory stimuli. For example, a person may mistake folds in the bedclothes for snakes, or the cord of a window blind for a stranger lurking in the room. The stimulus is a real object in the environment. However, it is misinterpreted and often becomes the object of the patient's projected fear. Illusions, unlike delusions or hallucinations, can be explained and clarified for the individual. Hallucinations are false sensory stimuli. Visual hallucinations are common in delirium. Tactile hallucinations may also be present. For example, delirious individuals may become terrified when they see giant spiders crawling over the bedclothes or feel bugs crawling on their bodies. Auditory hallucinations occur more often in other psychiatric disorders, such as schizophrenia and psychotic depression. The delirious individual generally has awareness that something is very wrong. For example, the delirious person may state, "My thoughts are all jumbled." When perceptual disturbances are present, the emotional response is one of fear and anxiety. Verbal and psychomotor signs of agitation should be noted by the nurse. A person with delirium becomes disoriented and may try to go home. Alternatively, a person may think that he or she is home and may try to jump out of a window in an attempt to get away from invaders. Wandering, pulling out intravenous lines and Foley catheters, and falling out of bed are common dangers that require nursing interventions. An individual experiencing delirium has difficulty processing stimuli in the environment. Confusion magnifies the inability to recognize reality. The physical environment should be made as simple and as clear as possible. Objects such as clocks and calendars can maximize orientation to time. Eyeglasses, hearing aids, and adequate lighting without the glare can maximize the person's ability to more accurately interpret the environment. The nurse should interact with the patient whenever they are awake. Short periods of social interaction help to reduce anxiety and misperceptions. Medical management is directed toward identifying and treating any underlying causes of delirium. Nursing interventions, however, are directed toward patient safety. It is important to communicate in simple and concrete phrases, speaking slowly with short, simple words, and focusing on one piece of information at a time. It is also important to maintain the same staff, if possible, so that the patient can begin to recognize people's faces. Encourage family members to be supportive and available to the patient. Keep distractions to a minimum and the room quiet at night for sound sleep. Always identify yourself and speak gently to the patient. Talk with the patient about familiar things in their lives. Reinforce reality when the patient is delusional. Have the patient wear eyeglasses or hearing aids, and use orientation tools such as clocks, calendars, and a well-lit room with family pictures. Prevent physical harm caused by confusion, aggression, or fluid and electrolyte imbalances. Perform a comprehensive nursing assessment to aid in identifying the cause. Assist with proper health management to eradicate the underlying causes, and use supportive measures to relieve distress. Dementia is caused by damage to brain cells. This damage interferes with the ability of brain cells to communicate with one another. When brain cells cannot communicate normally, thinking, behavior, and feelings can be affected. The brain has many distinct regions, each of which is responsible for different functions. For example, memory, judgment, and movement. When cells in a particular region are damaged, that region cannot carry out its functions properly. Different types of dementia are associated with particular types of brain cell damage in particular regions of the brain. In Alzheimer's disease, High levels of certain proteins inside and outside brain cells make it hard for the brain cells to stay healthy and to communicate with each other. The brain region, called the hippocampus, is the center of learning and memory in the brain, and the brain cells in this region are often the first to be damaged. That's why memory loss is often one of the earliest symptoms of Alzheimer's. In a normal brain, vitamin B12 allows cells to form new connections, a process that allows memory formation. Vitamin B12 is also a vital component of myelin, the coating that protects many brain cells. These roles of B12 could explain why low levels of the vitamin lead to dementia or memory loss. It's too soon to say for certain, but new research suggests people with vitamin D deficiency are more likely to develop Alzheimer's disease and other forms of dementia. For example, a study from 2014 published in Neurology magazine showed people with extremely low blood levels of vitamin D were more than twice as likely to develop Alzheimer's disease or other types of dementia than those with normal vitamin D levels. But it's important to point out that the association between vitamin D deficiency and dementia are only observational at this point. Vitamin D is vital to bone metabolism, calcium absorption, and other metabolic processes in the body. Its role in brain function, cognition, and the aging process is still unclear. Some suggest that vitamin D may be involved in a variety of processes related to cognition, but again, more research is needed to better understand this relationship. That being said, that is why it is important to start nourishment quickly on elderly patients in the hospital. They should never go more than 3 days without nourishment unless directed by the physician.
So thank you for coming out today. We're going to have a presentation about dementia recognition and treatment. I usually tell people a little bit about myself before I get started, so you know if the person that's speaking to you is qualified or not. It's nice to know. So I'm a social worker. I've been a social worker for 23 years. I have always specialized in Alzheimer's disease, end-of-life care. I was administrator of an Alzheimer's secured facility for 5 years. And this has just kind of been my dedication. And I'm a nationally certified care manager. So I've worked with seniors for a really, really long time, seen a lot of dementia care from early stage all the way till the end when someone's on hospice. Okay, so everybody asks, is it normal aging or is it dementia? So let's demystify that a little bit. So long-term memory loss, that's not a part of normal aging. If you really do have long-term memory loss, probably by that time you're in the moderate stage of Alzheimer's disease. Okay, usually Alzheimer's disease or dementia usually starts with short-term memory loss, and often it starts with depression even. Lots of research being done between depression and dementia. And most people who are diagnosed with dementia, if you look back 5 to 10 years prior to their diagnosis, many of them, over half of them, have been treated for depression. And it's not that they have major depression that they've had throughout their life. They've had some episode of depression, whether it's circumstantial from a death in their family or if it's just brought about. Short-term memory loss. Things you might want to think about is sometimes you enter a room and you wonder, what did I come into this room for? But about 30 seconds after you leave the room, you usually remember what you were there for. That's part of normal aging. Somebody with dementia will not remember what they had entered the room for. Same thing with word finding, when you're trying to think of someone's name or you know the name of an object, but the word is just not coming to your head. That happens to all of us. It's a normal part of aging, and I think it's just part of a busy life. Functioning is impaired. That's not a part of normal aging. That's really one of the red flags that this is probably something more, that it's not just memory loss. Because people with dementia, like I said, they forget how to do things in steps. That's why they have such a hard time with their activities of daily living, okay? Progression, if it's progressing, Might be dementia. It interferes with your thinking. Yes. If it interferes with your normal daily activity, you should go see a doctor. Okay, as I said before, age, biggest risk factor. Family history. I don't want people to think that Alzheimer's disease and dementia is hereditary. However, if you have what's called young onset disease, which means that you were diagnosed prior to the age of 65, or more in reality, if you've been symptomatic prior to the age of 65, because most people don't get their diagnosis until about 2 or 3 years after they've been having symptoms, okay? So that's considered young onset. Young onset Alzheimer's disease is found to run in families. Obviously, the family history like heart disease, the high blood pressure, those kinds of things can contribute. Plasma homocysteine, it's an amino acid that helps build protein. And so what they're doing is they're finding people that have a higher than normal level of this plasma homocysteine in their blood work tend to be at a higher risk because they tend to develop more of those plaques that I talked about on the brain. And then MCI, MCI, mild cognitive impairment. Has anybody ever known someone diagnosed with MCI? Yes, okay. The biggest difference between MCI and dementia is MCI has enough memory loss that it is noticeable. On a day-to-day basis with that individual, it's noticeable that they're having memory loss. The difference is it doesn't progress beyond memory loss. Whereas dementia, it often starts with memory loss, but then it starts inhibiting people in their daily activities, their activities of daily living. They no longer can, if they can't, maybe they can still get dressed, but the process of selecting an outfit becomes very cumbersome for them because it's hard for them to do sequential tasks or make decisions. Somebody with mild cognitive impairment, all they have is a memory problem, okay, and nothing else. Some people stay like that, or if they develop it late enough in life, all they ever have is mild cognitive impairment. But there are many, many people where MCI eventually advances into Alzheimer's disease. And then Down syndrome. Years ago, when Down syndrome children were born, their life expectancy was just in their early 20s. And one of the big reasons for that is because Down syndrome children typically have poor hearts. But now, with the miracle of medicine, and we have better prenatal care, right? We can correct things prenatally before or during gestation, and better treatment for their heart problems. People with Down syndrome are living longer. So what we're finding is when they're all aging into their late 50s, almost 100% of people with Down syndrome are developing Alzheimer's disease. So we talked about some of the risk factors. Now let's talk about prevention. So what are the benefits of knowing the risk factors? Knowing risk factors give you an opportunity for prevention. And remember earlier we talked about family history and how people with vascular disease also tend to have heart disease, high blood pressure, maybe even diabetes. Those are the lifestyle changes we can make that will help reduce our chances of vascular disease, especially vascular dementia. So live a healthy lifestyle. Eat foods that are low in fat. Eat brain healthy foods, things like blueberries, green leafy vegetables that are high in amino acids, even really dark chocolate that's at least 65% cocoa, and even coffee are all brain healthy foods. Don't smoke. We all know that to reduce heart disease and other diseases, including diabetes and high blood pressure, not smoking, not drinking excessively, all of those are good ways to reduce your chance of dementia as well. Research has really found that no matter what age you are, it's important to exercise your body and your brain. So even if you're sitting here and you're over 80 years old, it's not too late to get outside, start walking, exercise your body, challenge yourself by trying to learn new things. If you do crossword puzzles, do Sudoku instead and really get your brain working. Take a class, learn to knit. Even learn a musical instrument or try your hand at learning a foreign language. All those types of brain activities help keep your brain stimulated and reduce your chance of Alzheimer's disease and dementia. It's very important as a caregiver that you also care for yourself, especially if you're the spouse of the person with Alzheimer's disease or dementia and you're trying to care for them. Can you tell me if something happened to you tomorrow, what would happen to the person that you're caring for? It's really important to have a plan. And as much as we think that family will rally around us and help us, sometimes it doesn't work out that way. So as a caregiver, burnout is really a major factor, and your health is a major factor. And it's your responsibility to care for yourself because there's not somebody else there to do that for you. So there are some things you can do to care for yourself. And I always say that we need to care for the patient and the person caring for them, mind, body, and spirit. First of all, if you're still trying to care for somebody in their home, you can hire a company like ours to come in and provide you respite care in the home on an hourly basis. There's also many day programs in our community. And it's really important, I think, to set aside some money to manage what you need as a caregiver. I know we think that services are expensive, but if your health is jeopardized and that person later needs full-time care instead of family care, or if you have out-of-pocket medical expenses, that's going to be much more costly than just caring for yourself now. So you really should look at, are you having signs of depression? Are you having signs of fatigue? Make sure you go to the doctor once a year and get a good workup that you don't have high blood pressure. Because really, if you're not there to care for the individual, they're going to be left without a caregiver, and unfortunately that sometimes leads to early placement. I think it's also important to get yourself involved in a group. The Alzheimer's Association has a good list for you, but there are support groups for people with the frontal temporal that I talked about, with Lewy body disease. There are support groups for young onset or early stage dementia that both the caregiver and the patient can go to, especially if you're a couple, if you're a spouse. It's just really important to acknowledge all the losses that happen when you're a couple and one of the people has dementia. There are just so many issues of grief, of all the plans that you had for retirement that have now changed, and it's a lot to work through. So it's really important that you talk to somebody, that you care for what your emotional needs are, that you maintain your physical health, and that you continue to be there to be a good provider and caregiver to the person that you love who has Alzheimer's or dementia.
Ever since the first description of pre-senile dementia by Alois Alzheimer in 1907, the presence of cognitive impairment together with the formation of plaques and tangles have been regarded as the defining features of Alzheimer's disease. Many theories as to the cause of Alzheimer's have been proposed. Some research states that the hypothesis that the primary event in the onset of Alzheimer's disease is ischemic brain injury. Another theory states that the blood-brain barrier vessels are damaged and that at the same time cause the neurotoxic beta amyloid peptide to be released from the circulatory system into the brain parenchyma and subsequently react with ischemic neurons as secondary cause of neuronal death.
What is Alzheimer's disease? Alzheimer's is a slow, fatal disease of the brain affecting 1 in 10 people over the age of 65. No one is immune. The disease comes on gradually as 2 abnormal protein fragments called plaques and tangles accumulate in the brain and kill brain cells. They start here in the hippocampus, the part of the brain where memories are first formed. Over many years' time, the plaques and tangles slowly destroy the hippocampus, and it becomes harder and harder to form new memories. Simple recollections from a few hours or days ago that the rest of us might take for granted are just not there. After that, more plaques and tangles spread into different regions of the brain, killing cells and compromising function wherever they go. This spreading around is what causes the different stages of Alzheimer's. From the hippocampus, the disease spreads here to the region of the brain where language is processed. When that happens, it gets tougher and tougher to find the right word. Next, the disease creeps toward the front of the brain, where logical thought takes place. Very gradually, a person begins to lose the ability to solve problems, grasp concepts, and make plans. Next, the plaques and tangles invade the part of the brain where emotions are regulated. When this happens, the patient gradually loses control over moods and feelings. After that, the disease moves to where the brain makes sense of things it sees, hears, and smells. In this stage, Alzheimer's wreaks havoc on a person's senses and can spark hallucinations. Eventually, the plaques and tangles erase a person's oldest and most precious memories, which are stored here in the back of the brain. Near the end, the disease compromises a person's balance and coordination, and in the very last stage, it destroys the part of the brain that regulates breathing and the heart. The progression from mild forgetting to death is slow and steady, and takes place over an average of 8 to 10 years. It is relentless and, for now, incurable. Helping your family, friends, and neighbors to better understand Alzheimer's will reduce stigma, improve care, and even help the fight for a cure. Thanks for helping to do your part. Learn more at www.aboutalz.org.
Early Alzheimer's can be a slow process. These people often can still drive and live alone. Patients and families will notice forgetfulness and mild memory loss. Often, you begin to see it when people lose a word while carrying on a conversation. It is easier to identify when family or friends that have not seen the patient in a long time visit. The second stage of Alzheimer's is most commonly seen in the hospital setting. It is when people begin to require more assistance. You will notice that people cannot pick out appropriate clothing, forget to eat meals, become frustrated with daily activities, and will be found wandering and lost. In the hospital or nursing home, these are the patients that yell out for family members, even after they've been reoriented multiple times. They become upset with the staff when they are asked to eat, bathe, or socialize with others. This is a common problem seen in the nursing home. Stage 3 Alzheimer's is even more frustrating for the patient. They become depressed and withdrawn due to the inability to communicate, or may even forget how to walk, or become scared because they don't recognize anyone around them, including their own children. The late stage of Alzheimer's indicates death is soon to follow. In the final stage of this disease, individuals lose the ability to respond to their environment, to carry on a conversation, and eventually to control movement. They may still be able to say words or phrases, but communicating pain or other needs becomes difficult. As memory and cognitive skills continue to worsen, personality changes may take place, and individuals need extensive help with daily activities. This can include full-time, around-the-clock assistance with daily personal care, or ADLs, lose awareness of recent experiences as well as their surroundings, experience changes in physical ability, including to be able to walk, sit, and swallow, have increasing difficulty with communication, and become vulnerable to infections, especially pneumonia. When choosing a caregiver for the patient, they must be taught about the disease. Typically, with education comes greater compassion and understanding. They are taught how to handle situations and when more help may be needed. Respite care is often required for families who care for patients with mental illness at home. They need to be able to care for themselves, and the only way for that to occur is to have another person who can come in and manage care for short periods of time so that that immediate caregiver can have rest. Mild cognitive impairment, or MCI, causes mental changes that are serious enough to be noticed by the individuals experiencing them or to other people, but the changes are not severe enough to interfere with daily life or independent function. MCI that primarily affects memory is known as amnestic MCI. With amnestic MCI, a person may start to forget important information that he or she would previously have recalled, such as appointments, conversations, or recent events. MCI that affects thinking skills other than memory is known as non-amnestic MCI. Thinking skills that may be affected by non-amnestic MCI include the ability to make sound decisions, judge the time or sequence of steps needed to complete a complex task, or visual perception. Mild cognitive impairment is a clinical diagnosis representing a doctor's best professional judgment about the reason for a person's symptoms. If a physician has difficulty confirming a diagnosis of MCI or the cause of it, biomarker tests such as MRIs, cerebrospinal fluid tests, many mental exams, and neurological exams may be performed to determine if the individual has MCI due to Alzheimer's. Amnestic disorders are a group of disorders that involve loss of memories previously established, loss of ability to create new memories, or loss of the ability to learn new information. As defined by the Diagnostic and Statistical Manual of Mental Disorders, or DSM, the amnestic disorders result from two basic causes: general medical conditions that produce memory disturbances, and exposure to a chemical such as a drug of abuse, medication, or environmental toxin. An amnestic disorder whose cause cannot be definitely established may be given the diagnosis of amnestic disorder not otherwise specified. Amnestic disorder due to a general medical condition can be caused by head trauma, tumors, stroke, or cerebrovascular disease. Substance-induced amnestic disorder can be caused by alcoholism, long-term heavy drug use, or exposure to such toxins as lead, mercury, carbon monoxide, and certain insecticides. In cases of amnestic disorder caused by alcoholism, it is thought that the root of the disorder is vitamin deficiency that is commonly associated with alcoholism, known as Korsakoff's syndrome. Amnestic disorders related to alcoholism usually do not clear up, but slowly progress with thiamine treatment. Perception in a patient with a neurocognitive disorder is typically skewed in some way. They may not know the date, time of year, or people around them. They can also see things that are not there. Their attention span becomes very short or non-existent. They cannot follow any commands, or they may try and fail. Patients who are confused or impaired neurologically may use profanity or begin to mumble when they speak. Language becomes incoherent, although they think they are making sense, causing increased frustrations with caregivers. The individual's behavior and mood may change dramatically within a short period. Moods may fluctuate from fear, anger, and anxiety to euphoria, depression, and apathy. These labile moods are often accompanied by physical behaviors associated with these feelings. A person may strike out from fear or anger, or may cry, call for help, curse, moan, and tear off clothing, and then, within a minute, become apathetic or laugh uncontrollably. In short, behavior and emotions are erratic and fluctuating. Lack of concentration and disorientation complicate interventions. Depending on the stage the patient is in, assessment findings will vary. Eating habits will change. The person either forgets to eat, they are no longer hungry, or the drive to eat is just not there. Aspiration is also another major consideration. People forget how to eat and swallow, causing them to choke. The part of the brain that tells them to swallow forgets to fire. Nutritional considerations are made, such as feeding tubes or thickened liquids and mechanically altered foods. As eating habits change, fat loss occurs and skin becomes very thin. The person then begins to complain of being cold. Those with neurocognitive disorders often have changes in their gait as well, such as shuffling when they walk. The neurotransmitter dopamine is involved in the coordination of smooth and complex movement. Dopamine deficits result in impaired motor activity. Severely decreased levels of dopamine in individuals, such as those with Parkinson's disease, cause the disorder's most characteristic symptoms, such as resting tremors, rigidity, slow movements, and postural instability. One typical outcome for the delirious patient is that they return to their baseline functioning. If the treatment is provided quickly, the delirious state will resolve rather quickly, and the patient can return home or their residence after discharge. Outcomes for patients with major cognitive disorders revolve more around keeping the patient safe. For example, you would use risk for falls, aspiration, and inability to help in self-care. Nurses tend to focus on the caregiver, especially with caregiver role strain. Families and other caregivers become frustrated easily. The inability to communicate does not only upset the patient, but the person who is trying to understand what the patient wants and needs. These caregivers also have to take time to care for themselves and other family members as well. Upon discharge from the hospital, patients with cognitive disorders tend to be admitted to rehab or long-term nursing facilities. They require more care than what can be given at home at that time. Perhaps the patient had a fall and needs to be rehabilitated and then can come back to the family's home. Depending on the patient and the family situation, planning needs to occur to keep the patient safe. In the hospital, case management typically becomes involved as soon as the nurse or physician identifies a caregiver situation. When long-term care is decided upon, it is important for the healthcare team to involve not only the family but the patient as well. It is also important for the family to ensure that the patient is allowed to help with decision making. The patient should be allowed to continue as many of their own activities as possible, helping to maintain their independence. Socializing them in the new environment will allow them to make new friends, and in turn, hopefully slowing down the depressive symptoms that may ensue. As symptoms worsen, caregivers need to give consideration to the patient's disability. Slow down when speaking or giving commands, break information down into smaller pieces, and do not show dissatisfaction when the patient is unable to perform a task as quickly as they once were able.